I'm unfortunately the only one in this committee today. Everyone's a bit busy today. So if you have any questions, let's perhaps leave them towards the end just so I don't get lost in the chat, but I'll try and do my best between learning outcomes to answer them. So welcome if you're returning, okay? And welcome to everyone who's new to this webinar. This is lesson 7 on glaucoma, but all our previous lessons are uploaded on YouTube. So just visit our website if you want to see all our previous lessons or touch base with them. My name's Yarrow. I'm a doctor from Brighton. Okay, so I'm a foundation year 2 doctor. So that means I'm probably 1.5 years out of uni, and we're applying for ophthalmology this year. So a lot of us have tried to design a course to help both us study the basic concepts as well as let students kind of pass the Duke Elder, which is it's like a national exam that ophthalmologists or wannabe ophthalmologists sit, hence Slam Dunk Elder or Slam Dunk Duke Elder, okay? We're a committee of 3, okay? There's myself, Tom Hickman Casey, and Reza Owasil, who sadly does not have a professional photo, but we're essentially trying to help everyone pass the Duke Elder, which is very much plausible. If you want to get top marks in the Duke Elder or be in the top 20%, get in touch after the seminar and we can talk about it. But it's a lot of effort, but it's not impossible either. But to pass is quite easy. And that scores you 1 point in your future training if you want to be an ophthalmologist. So the learning outcomes for this webinar, okay, we're talking about glaucoma today, which is stereotypically seen as a very boring condition, but I'm going to try and convince you otherwise in this lesson, okay, that glaucoma is not boring. It's not just a case of changing drops every time someone comes in with slightly elevated pressures. And in fact, it's not always linked to pressure, okay? Glaucoma comes in multiple formats and is always interlinked with other conditions and can be a complication as a result of other conditions. So it's quite important for a general ophthalmologist or a specialist ophthalmologist to know about glaucoma medication, okay? So we'll understand glaucoma as a disease process and its importance. We'll appreciate the different types of glaucoma, outline the signs and symptoms of glaucoma, the investigations, and hopefully the management of glaucoma. And some of the surgery in glaucoma is becoming revolutionary, okay? They're moving into a territory known as minimally invasive glaucoma surgery, which is making their kind of practical skill force or workforce very exciting. So their theater operations have become a lot more cooler than they used to be. So the surgery is cool in glaucoma surgery. Okay, so hopefully you've all had a go at the quiz. If not, have a go at the one at the end, okay? So let's talk about glaucoma. Ignore the references, I should have got rid of those, but essentially, glaucoma is a chronic and irreversible condition that affects primarily the peripheral vision, which eventually, if not treated properly, will lead to a decay in central vision. So it starts by your outer peripheral vision, and hence I've popped a picture here of a tunnel. So it's routinely or characteristically referred to as tunnel-like vision. And equally, it's referred to as the silent thief of sight, primarily because even though you're losing peripheral vision, our brain tends to ignore a lot of what we see peripherally anyway. So unless from an evolutionary perspective, our brain's been programmed to recognize something moving really fast or a sudden color change in our peripheral vision, a lot of what we see that's mundane throughout our lives gets ignored in our peripheral vision. And hence, if glaucoma starts to creep into anyone's adult life, okay, we tend to not notice it until it becomes very end stage. And almost 40% of ganglion cells can be lost. These are the kind of nervous system cells, okay, that supply the retina, can be lost by the time that we notice any visual field defects. And we report that to the ophthalmologist or the optician ourselves, okay? So it's a silent thief, if that makes sense. And we usually get tunnel vision as a characteristic description of how the vision changes from peripheral to eventually central. It's responsible for 8% of the global blindness, okay? So it's not insignificant either globally, it has quite a big impact, and it is the #1 cause of irreversible blindness. I'm stressing irreversible here because the #1 cause of reversible blindness is cataracts in Western society, okay? Glaucoma is also the second most common cause of registration of visual impairment as well as blindness in the DVLA, okay? The first being AMD and macular degeneration, okay? So it's the second most common cause of people going blind and being registered for kind of sight benefit costs, okay? And it's a major burden to ophthalmic units. So about 1 in 4 patients who visit a tertiary unit in ophthalmology will have glaucoma as a comorbidity or as an past ocular history, okay? So it's a big burden on glaucoma units, especially if someone comes in as a glaucoma suspect, which we'll talk about, and has been inappropriately referred to this kind of large waiting list. We have this big dilemma, okay? And because it's chronic, people need regular follow-up, which usually is 6 to 12 monthly, depending on how severe the glaucoma is, but can be more frequent. Okay, so glaucoma is important. Here, tunnel vision. Here is an optic cupping scenario, okay? So we see the optic kind of cup essentially much larger than expected, and it's approaching the kind of rim or the optic disc. And we'll talk about assessing this later on, okay? So this is a busy slide, I apologize. It's just coming back to kind of a few anatomical concepts as well as physiological concepts, okay? Just a few definitions more than anything, okay? That's all you need to take away from this slide and a few pretty images. The retinal nerve fiber layer, okay, is, gosh, where is it? It's here, okay? So it's the second layer of the retina. The retina has up to 10 plus layers, okay? And you don't need to know all of them, but the retinal nerve fiber layer is where all the neurons or the axons of the neurons travel to reach and form the optic nerve, okay? So they all travel in this kind of very unique pattern known as an arcuate pattern, arc, okay, it being an arc-like shape, and they travel to the site of the optic disc, and then they kind of do a 90-degree turn inwards and then out through the skull. They all join to form the optic nerve, okay? So that's what the retinal nerve fiber layer is, and it's just ganglions of cell axons that follow a specific pattern. Depending on, the majority follow this arcuate pattern, but the ones that are slightly closer to the disc, so for example, these peridisc ones, okay, peripapillary ones, as well as ones close to the fovea, tend to follow a slightly different route, and it's known as a linear route. So they go directly straight over there rather than looking arcuate. Obviously, a diagram sadly will never do it justice, but that's just what you need to know from a theory perspective. Fovea / close to the disc, they follow a straight line in, whereas everything else has to do this kind of arcuate pattern, okay? Just a bit more anatomy definitions, okay? So the optic nerve head, there'll be a few more diagrams after this, so don't stress too much. But the optic nerve head, i.e. the optic disc, is essentially this kind of wider area here, okay? So this is a FFA image, meaning that basically contrast has been injected into the eye, and the optic disc is this kind of outer circle. Anything out here is kind of peripapillary, okay? Optic disc here, and then you've got an inner circle known as the optic cup. And there'll be a few more images just where I'll try and emphasize this point. It's just an anatomical term. So the optic nerve head, where all the fibers kind of go 90 degrees to form the optic nerve, is known as the optic disc, okay? And the optic cup, okay, this kind of darker area is a site of kind of anatomical depression, essentially. It's a site within the optic disc, okay, where there are no axons, okay? It's not occupied by anything. It's an anatomical point where there is basically a lack of stuff, okay? So that's why we get this kind of optic cup to disc scenario going on, okay? Where glaucoma surgeons and a lot of ophthalmologists talk about, hey, what's the cup to disc ratio, okay? So the cup is the inner circle and the disc is the outer circle, okay? Hopefully that's making a bit more sense, but I'll show you some more pretty pictures, okay? You've got to kind of put on your 3D anatomy hats here, unfortunately. So that's why more pictures usually help. But essentially, anything here blue is the optic cup, okay? It's an anatomical depression with no axons through it, okay? All the axons dive down at around the optic disc area, okay? And the region where essentially this region here in red is known as the Neuroretinal Rim, okay? There's a lot of terms being thrown around here, but just a few key ones that you need to know about. The optic cup is the inner circle, okay? This inner circle, right? and it's an anatomical depression where there's no axons. The outer circle is the optic disc. This is where all the axons start to dive down at a 90-degree angle to form the optic nerve. And the area that's in between the optic cup and the optic disc is very rich in axons, and it's known as the Neuroretinal Rim, okay? Hopefully that makes sense. So this is dense in axons, no density in axons, or nothing pretty much here. Neuroretinal rim, optic disc, optic cup, okay? And it all forms to form this optic nerve, which leaves and forms the optic tract, okay? To reach the lateral geniculate nucleus at the back to form the kind of V1 striations, okay? And it's all supplied by the central retinal artery. So the central retinal artery is a branch of the ophthalmic artery. It comes out, it kind of resides on the surface of the optic nerve, and then it kind of comes through the optic cup. Okay, that's convenient because there's no axons here, so it has space to go through without disrupting vision, and travels to supply basically the superficial retina with its kind of superficial branches. Okay, so that's just a bit of anatomy. Okay. Moving away from the optic disc, we'll come back to it again. We talk about the aqueous flow and how it's produced, okay? The aqueous flow dynamics is a bit complicated, but all you need to know for the sense of ophthalmology as well as Duke Elder is the fact that aqueous is produced by the ciliary body. If you want to go back to our physiology lecture, it should be lecture 2 on the YouTube series, but it's produced by the ciliary body, okay? And then it flows from the ciliary body, okay, from the posterior chamber, just behind the iris, forwards and into the anterior chamber. And then it gets sucked up by this sink kind of mechanism known as trabecular meshwork, okay? Everyone talks about Schlemm's canal, trabecular meshwork. They're all kind of used interchangeably, but they actually subtly mean different structures, okay? In this kind of what we call the gross structure as the angle of drainage, okay? So if you want to use an all-encompassing term and you want to be pernickety about it, it's officially called the angle of drainage, and then all the individual structures have a specific component that forms up the angle of drainage, okay? So this is the angle of drainage as a gross structure. It's made up of multiple layers. So on the outside, you have the uveal tissue, okay? That's the first kind of fenestrated layer for kind of, it's like a sieve, basically. When you put the sink on, imagine like the sink tap is your ciliary body. It's just producing aqueous, and the aqueous flows, if you look at the camera, the aqueous flows from the ciliary body, travels along the iris posterior chamber, and then it kind of flows anteriorly through the pupil aperture into the aqueous chamber, or the anterior chamber, sorry. And then there needs to be a drainage process to kind of make sure the eye doesn't basically explode eventually. Otherwise, too much water with no drainage leads to a bad homeostatic system, doesn't it? So the angle acts as a sieve, okay, like a kitchen sieve or a sink, essentially. It acts as the pipework that kind of homeostates and regulates how much aqueous fume is produced. And it's made up of multiple structures, all of which I'm sure you probably heard of during our kind of lecture series, okay? You have the uveal tissue, you then have the corneoscleral tissue, which is in red. Then you have the juxtacanalicular tissue, okay? Juxtacanalicular tissue, which is also composed of endothelial cells, okay? And then you have the Schlemm's canal, which is the final kind of drainage output before it reaches a venous system, okay? So through this sieve-like structure, we are able to regulate aqueous humor. And if anything were to ever go wrong here, this is how we get a buildup of intraocular pressure, which might predispose us to glaucoma. And I just reiterate, 90% of aqueous humor is recycled/drained through this mechanism, the trabecular network or outflow mechanism. 10%, less common or less likely, is drained through the uveal scleral outflow mechanism, okay? That means it essentially goes through venous channels that aren't related to this, and they're usually located around the iris/through fenestrations in other parts of the eye. So 10% goes through this mechanism, less common, and most of it goes through this kind of angle drainage mechanism. And this is just a complicated diagram about physiology. I don't think we should touch base, but it relies fully on a lot of electron/ ion distribution to create these kind of gradients to allow aqueous to be produced and the flow of water to follow with the aqueous, okay? So that's just all kind of recap, okay? You all knew that, I promise, okay? And when we, as ophthalmologists, are assessing someone's angle and how it drains, we tend to employ a fancy mechanism known as a gonioscope. It's just a very fancy lens that has a has three mirrors. And these mirrors essentially just angle towards the person's angle, essentially. So they angle towards the angle and you kind of get this slightly more warped image, but you can look at the individual structures of the angle to make sure that they're all functioning. And typically, if you're very well versed in examining someone's angle drainage system, I'm personally not, but you look out for particular anatomical kind of networks. If you see stuff that's not in keeping with these kind of networks, then there might be something going on, such as new path processes. So sometimes there might be deposition of inflammatory cells or some fibrin deposition there, and that might be suspicious for why the angle might be blocked, for example, and causing some form of glaucoma, okay? Sometimes there might be trauma. So you might get dialysis of kind of basically you might get these different lines that spread apart. Okay, they've been spread apart because there's been a traumatic process that's occurred. And so you get a disruption to the angle or the trabecular meshwork altogether. Ignore the pigmented and non-pigmented cell differentiation, but essentially the non-pigmented cells, as we've seen here, are the ones that are primarily responsible for producing these gradients that allow us to have aqueous diffusing across, as well as being movement of ions to allow this aqueous channel to flow from the posterior chamber into the anterior chamber, all right? Okay, this is all recap, okay? But also we're just trying to repeat stuff just so we kind of get a clearer picture every time. So glaucoma is in fact, despite what people like to think, it's a collection of diseases, okay? It's an all-encompassing term for a collection of diseases, and there is a multitude of forms of glaucoma, okay? And we'll talk through each one, and we'll try and keep it superficial. But glaucoma is a disease that is defined as some optic damage, okay? So you have optic neuropathy of some form, meaning there's either retinal ganglion cell loss, or there is optic nerve or optic cup damage, okay? So it's an optic neuropathy primarily. That produces a visual field loss, okay? You need those two elements to define glaucoma or any form of glaucomatous condition. You need those both elements, optic neuropathy or some form of retinal damage and visual field loss, okay? The condition is usually associated with a raised IOP. And IOP just means a raised intraocular pressure. And our range of intraocular pressure is between 10 and 21. If it's below 10, we call it hypotony, okay? So reduced pressures. And if it's above 21, it's hypertony, okay? Or glaucoma, or sorry, not glaucoma, or raised IOP. And typically, raised IOP is associated with glaucoma, but it's not a defining feature, okay? And this is where the beauty of glaucoma research is coming in, because we've learned a lot more to then just say high IOP equals you will get glaucoma. We obviously want to keep the IOP in a good range to prevent damage, but ultimately it doesn't, there are other mechanisms as to what happens to lead to glaucoma, not just raised pressures. So glaucoma, from your first kind of definition, is stratified into two subtypes. Either the angle of drainage is open or it's closed, all right? So it's either open or it's closed. And then we have primary/secondary causes. When we mean primary causes, it usually means stuff that's related to, for example, aqueous humor physiology, okay? If it's a secondary cause, it's usually some form of disruption to that dynamic, okay? That's come from a different condition altogether. For example, you might get inflammatory conditions such as uveitis. You might get these unique conditions known as pigment dispersion and pseudo exfoliation, where there's basically dandruff-like protein that's trickling into the trabecular meshwork or to the angle and clogging it up. Similar, on the closed angle side, you have other conditions. Once again, inflammatory pops up again, and rubiotic, which is basically vessel growth that cause a blockage of the angle, okay? Anything to do with aqueous flow disruption is usually under the primary heading, okay? So we'll talk through all these different types. Another term that usually gets thrown around a lot is glaucoma suspect, okay? This is basically, it's like a pre-glaucoma state. As ophthalmologists, we try and capture people who are high risk for developing glaucoma, okay? There are a few risk factors that you should know about, okay? And these people who are high risk for developing glaucoma, we call them glaucoma suspects. Or if they start to develop any signs that are consistent with potential diagnosis of glaucoma, we might call them a glaucoma suspect. For example, if they start to develop cupping features or a larger cup, okay, or an asymmetric cup compared to the other eye, then we might call them a glaucoma suspect, but they might not have any optic neuropathy yet, okay? So remember, glaucoma requires two things to make the diagnosis, okay? You need nerve damage, optic neuropathy, and you need visual field defects, okay? It means it's having a clinical impact on how you see or perceive the world. That's the definition of glaucoma. So if you have one or the other, or are at risk of developing glaucoma because of these beautiful risk factors, then you're probably known as a glaucoma suspect, and you will still require follow-up and some form of regular monitoring of your pressures in your eye, okay? The classic suspects or the classic risk factors are a raised incidental IOP. Sometimes that's found on routine screening when you go to the opticians, when you have your glasses upgraded, diabetes, use of systemic as well as topical steroids. Steroids do a lot of bad things to the eye, and one of them is unfortunately glaucoma as a complication, but they're also very helpful in treating infections and inflammatory conditions. So it's kind of a double agent here, or double-edged sword. Increasing age, unfortunately, as you age beyond 40 and especially 60s, your kind of risk factor for developing glaucoma increases substantially. Unfortunately, Afro-Caribbean ethnicity, okay, leads to an increased risk of glaucoma, as well as having some family history, okay, and being myopic. Myopia is short-sightedness, okay, and it's because you have a rugby bowl shaped eye. And as a result, you have slightly narrower chambers anyway as a result of that, okay? And the modifiable risk factors in this scenario tend to be diabetes, okay? As well as probably steroid use, sorry. So the modifiable risk factors amongst these 7 tends to be diabetes, so you can get better diabetic control, as well as whether you need to be taking topical systemic steroids, so you can take those off, okay? Everything else, unfortunately, is linked to non-modifiable risk factors. So that's why these people require closer surveillance for their potential to progress to glaucoma. So what's the pathology in glaucoma? Okay, remember we divide it into open angle and closed angle, okay? And it's as simple as that. We have open angle glaucoma, which tends to have an open angle and a drainage network that's actually working. And then we have closed angle glaucoma, where the iris happens to be touching the corneal endothelium and is no longer draining, okay? So those are the primary mechanisms of glaucoma. And it's, as I said, it's typically associated with pressure, but it's not always associated with pressure in that sense. There are forms of glaucoma that are not associated with pressure. Sorry, one of my flatmates has just entered the room as always. There are some forms of glaucoma that aren't associated with high pressures, but other forms, more commonly, we'll talk them through, have a raised intraocular pressure, okay? And pressure, essentially, there's multiple theories as to why pressure affects the retinal ganglion layers, okay? But one of the theories is the fact that the lamina cribosa, okay, this is an anatomical structure that holds together all the axons that form the optic nerve. That gets damaged in the process of high pressures leading to mechanical damage. So that lamina cribosa, this kind of connective tissue that holds together, like gosh, I don't even have an analogy for this, but it's a connective tissue that holds all the nerves together, a bit like the outer coating or kind of the glue that sticks it all together. It gets damaged in the process. And so there's resultant kind of dysfunction of axons as a result. More pressure changes include neuronal glial cells. They get affected. So these are the kind of support cells, the astrocytes and microglia that support the axons and the neurons that form the retinal kind of layer. These support cells get damaged due to the increased pressure and the remodeling that occurs due to this increased pressure. So the microenvironment changes and leads to axonal death. We also have metabolic stress as an increased amount of, once again, probably linked to pressure. There's disruption of these axonal transports and atrophy of the kind of support cells that leads to subsequently increased reactive oxygen species. And as a result, this leads to mitochondrial dysfunction when the mitochondria are no longer able to clear away the large amount of reactive oxygen species. Okay, so there's a metabolic stress component. And more research is identifying certain genes that code for protein as well as structural tissue that might be dysregulated in glaucoma. In particular, there's protein that's been associated that produces the lamina cribosa. So certain genetic conditions or genetic allele mutations lead to a slightly poorer lamina cribosa formation. And if you aren't able to kind of tighten or structurally support the axons, they kind of just dysregulate and atrophy themselves if there's no support network like the lamina cribosa. So these genes are associated with proteins and support tissue that might be dysfunctioning as a result of that. Okay, so that's the kind of pathology. So I think things will become a bit more clearer as we talk through the different types of glaucomas and the classical signs that we might see with these different types of glaucoma. Remember that we subdivide into open angle and closed angle glaucoma. And that's primarily the pathophysiology that occurs, okay, to allow us to develop raised pressures as well as neuronal damage, okay? I can't see any questions yet on the chat, so that's reassuring, but let's leave them towards the end if we can, and I'm happy to answer any towards the end, okay? There are loads of different types of glaucoma, and we're gonna walk you through each individual one, but as you can see, it's quite an all-encompassing condition, okay? And remember, the two things that are required to diagnose someone with glaucoma is optic atrophy, or sorry, optic neuropathy. Optic atrophy is a very end stage sign. Optic neuropathy and visual field defects. So that's a clinical sign that you elicit from a patient, okay? So ocular hypertension. This is a bit like a glaucoma suspect. This is just a person who has no optic neuropathy or visual defects, but has a raised IOP or an intraocular pressure. They're known as ocular hypertensives, okay? They are at risk. They're a risk factor for developing subsequent glaucoma. And it's your usual classical risk factors: family history, Afro-Caribbean origin, steroid use that's systemic or topical, and increasing age, okay? It's a bit like having high blood pressure. Everyone eventually gets it, okay, through our lifestyles. These individuals are asymptomatic, but they require follow-up because they can progress to primary open-angle glaucoma, okay? And there's been a big study done, a prospective study following people up, okay? And it basically said, do we treat these people early on, despite no clinical signs or not being glaucomatous, okay? Do we treat these people early on with ocular hypertensives? And the answer is yes. We provide them anti-ocular hypertensive medication, okay, early on, despite having no clinical signs or no damage, because it's preventative and it halts the progression. So this is a curve that shows halted progression down here with people who've been treated. And then the dotted curve are the people who haven't been treated and their progression rate towards, okay, remember their observation, okay, versus medication, towards glaucoma. And there's quite a stark difference at each kind of grading, okay, a follow-up. So we treat these people to prevent progression. That's ocular hypertension. Right, primary open angle glaucoma. This is the one, okay, that is slightly counterintuitive in my head personally, but the angle is open, so the drainage is working. However, we still have a high intraocular pressure causing neuronal damage or having clinical signs. Okay, so in primary open angle glaucoma, the problem is not with the fact that there's a closure or an obstruction, there is increased resistance to flow. Whether that means that anywhere along the aqueous pathway, there is some form of resistance or particularly in the trabecular meshwork, there's been some form of protein change or mutation that's led to slightly less fenestrations in the trabecular meshwork. As a result, there's an increased resistance. So the angle is dysfunctional rather than necessarily obstructed, if that makes sense. Okay, so that's what primary open angle glaucoma is. Third world leading cause of blindness, okay, 8% from the initial slides, okay. It is associated with a raised intraocular pressure because if there's resistance, the pressure just builds up in the anterior chamber. And the theories, once again, as to why nerves get damaged in this process is because, well, the pressure either compresses small vasculature that supplies the neuronal tissue. Okay, remember that the ophthalmic artery divides into the central retinal artery, and when that central retinal artery penetrates the optic cup, okay, through the degenerated axons, okay, through the optic cup, there's no axons there, so it's no problem for the artery to travel up that way, and then sends off its branches, okay, the superficial temporal, the inferior temporal, the nasal branches of these small little vessels. This IOP mechanism, or raised IOP, can suddenly lead to compression of these arteries, causing basically an ischemic change that's chronic in nature. So it doesn't manifest itself as central retinal artery occlusion or a branch retinal artery occlusion. It manifests as chronic kind of degenerated supply of nutrition to these nerves, and it leads to ischemic changes, okay? Or it's a direct impact on the actual neurons that lead to eventually axonal death and apoptosis, okay? So the pressure either compromises the supply or the actual neurons themselves. The classic signs in primary open angle closure, no brownie points, but open angle, okay? So you can identify that on a gonioscope. You have your classic signs of glaucoma, which tend to be raised IOP, which can be identified on a Goldman tonometry. I'll talk about that later. Reduced visual acuity, optic disc cupping, and visual field defects, okay? This one I'll talk about later is a classical sign because of the fact that the pupil changes, and when the pupil constricts, the angle opens up, okay? So sometimes change in light scenery precipitates certain symptoms of glaucoma because the pupil's changing size, and when it's constricted, myotic, then the angle is more open. When it's dilated, mydritic, okay, then it's more scrunched up into the angle, and so it can precipitate glaucoma. Management is the same as any other form of glaucoma. Ocular antihypertensives, and you try and aim for either a certain reduction in IOP, or you start to aim for target pressures, for example, and that will be unique to every individual person. If it's not medically being managed, you aim for trabeculectomies or surgical management, and I'll talk about those options later. Normal tension glaucoma, even more mysterious than primary open angle glaucoma. Here, it's a very ominous condition that no one knows much about, unfortunately, but in these individuals, there's no pressure change. In fact, the pressure tends to be on the lower side or the lower threshold, or it tends to be in the normal range of 10 to 21. It's typically associated with systemic conditions such as poor blood pressure control, migraines, vascular insult, and all these kind of conditions are kind of vasculopathic in nature. So either there's some form of pathophysiology with vasospasms or lack of oxygen supply that's occurring. No one knows the actual pathophysiology of normal tension glaucoma, but it's a variant of primary open angle. So the angles are open, but the pressures are normal, okay? Very strange, but associated with these kind of systemic conditions. One hypothesis is also the fact that maybe the lamina cribosa, this kind of structural connective tissue at the optic nerve head, that is abnormal. So maybe there's some genetic factors that contribute to the tissue or the proteins that form the lamina cribosa, okay? Classic signs for normal tension glaucoma are almost pathognomonic. They're slightly different to other forms of glaucoma. So you'll usually get the optic disc cupping, optic neuropathy signs, the visual field defects, but you also get peripapillary atrophy, and it's usually focal in nature. So for example, there'll be a segment which is slightly lighter or slightly darker, or there's a segment of atrophy. For example, this might be a peripapillary atrophy segment. It's focal compared to the other forms, okay, slightly brighter, indicating there's atrophy because you can see through to the back. You get focal notching and thinning, meaning that basically it's segmental rather than kind of systemic, if that makes sense. the peripapillary atrophy and the actual decay in the optic disc is local. It's like basically a certain segment of pizza, rather than the whole pizza slice being affected. It's a certain segment of pizza being affected. And you get these characteristic Drance hemorrhages. Drance is, I think, an ophthalmologist who identified them, these early signs, and these are your Drance hemorrhages. They're essentially like flame hemorrhages that are just basically close to the disc, okay? So if they're isolated and found, if you find hemorrhages that are isolated and close to the disc, you might be assuming that this might be a glaucoma suspect, okay? They're known as Drance hemorrhages. And even weirder, I find even weirder, is the fact that normal tension glaucoma, despite having normal pressures, still gets treated with anti-ocular hypertensives. So for these individuals, either we have nothing better to offer them, and we don't know enough yet to kind of offer them sensible therapy, but we still treat them with the same stuff we treat with every glaucoma condition. So correct me if I'm wrong, but that's my understanding. So you still treat them with ocular antihypertensives, but you might focus a bit more on systemic issues, such as correcting blood pressure, any migraines, anemia, all these other medications you can provide people, okay? So, and this has been verified by a study. So it's a bit counterintuitive. Normal tension glaucoma, I don't think we know much about, sadly, at this stage, but this is the synopsis. Acute angle. This is an emergency. It's probably one of 7 ophthalmology emergencies. And once again, what makes ophthalmology such a fun specialty, because there's only 7 conditions that will get you up at night to actually go see a patient if you're on call, okay? And this is one of them, unfortunately. Acute angle closure glaucoma needs to be acted on very quickly because it's usually a medical legal reason, because you can lead to permanent vision loss, okay? So this is probably, out of the 7 conditions, this is even higher up in your priority list, because depending on how high the pressures are and how severe the glaucoma is, then will depend on how quickly the person might lose vision. And losing vision is absolutely a never event, if that makes sense. If it can be avoided, it should be avoided. It's an ophthalmic emergency. As the name suggests, it's closed angle, and it's usually precipitated, if that makes sense. So by precipitated, I mean usually either the individual does something, and they're usually labeled as an unknown glaucoma suspect, or we do something to the individual, such as pop some drops that dilate the eye, like atropine, and suddenly there's a dilated pupil that scrunches up into the angle and affects and obstructs the drainage of the angle. So typically people might say certain stress, fatigue, or if they've gone into a suddenly darker room where the pupil dilates, okay? Or if they say it's suddenly come on in the evening, for example, this is all related to the fact that the pupil becomes blocked in a certain position. It dilates and becomes blocked. And it's blocked usually because of a spasmy approach to the pupil. I'm not too quite certain as to why it doesn't suddenly constrict again, but it becomes blocked in that position. And as a result, being close to the angle, it obstructs the angle and causes a sudden rise in intraocular pressure. And so we classically get this kind of picture of cloudy cornea because the cornea is getting edematous. It's not being fed by the aqueous humor, and a fixed mid-dilated pupil, which is kind of blocked. So it won't respond to light, unfortunately. Because acute angle closure is so painful, it leads to a very raging headache, as well as associated with that headache, you might even vomit from the pain. So, and equally, because the cornea is getting edematous, you tend to see halos around lights, or your kind of window into your retina is not working as well. Also, what you can potentially sometimes elicit, because there's such a buildup of pressure, there's essentially almost like a forward displacement mechanism of the iris. And this is a cool sign known as iris Bombay. I'm not sure, this is the first time I've heard of it, but the iris essentially almost prolapses forward, and it's almost a sign of obvious obstruction of the angle. Here, there is no space for aqueous to drain. If you imagine that's your angle down here, the iris is prolapsed forward because there's a sudden buildup of pressure, and that's it. It's stuck and adhered to the endothelium of the cornea, essentially here. The angle's blocked as a result of that. That's known as iris Bombay sign. And here we have an iridotomy, which is essentially a laser that's fired through the iris to help create a bypass channel for aqueous to drain. So this is usually some ophthalmologists relieving the acute angle closure by doing an iridotomy, a peripheral iridotomy. That's what PI means. So that's why you usually tend to get up in the night to do these procedures, because acute angle leads to vision loss that's permanent in nature. Equally, in the meantime, by the time the ophthalmologist wakes up, gets ready, brushes teeth to get to the 2 a.m. on-call site, they might ask the SHO or the F1 on-call to start IV acetazolamide, 500 milligrams, which might be then switched orally to acetazolamide, okay? As well as a few topical antihypertensive, cycloplegia, and steroids, okay? So this is an ophthalmic emergency. There's medical things that we can do to decrease the pressure, but ultimately we need to do an iridotomy in the acute phase to kind of allow a bypass of aqueous drainage. And we do it usually bilaterally to both eyes, because if one eye is to clog up, then the other eye might also clog up eventually, okay? Brilliant. So next we have inflammatory and uveitic glaucoma, okay? We talked about this, I think, in lessons 5 maybe or 4 about uveitis and how a complication of uveitis, because there's so much inflammatory debris / immune cells flood the area. Remember, the eye is an immune privileged organ. It doesn't want the immune system flooding if it can handle it with local kind of resident cells. As soon as the immune system floods the area and clogs up everything, the angles can also get clogged up. Okay, so uveitic glaucoma or inflammatory glaucoma is usually due to uveitis. There's usually obstruction of the angle, and sometimes you even get inflammation involving the trabecular meshwork, known as trabeculitis. And there is also leakness of blood vessels by the fact that we have a loss of blood aqueous barrier, because loads of prostaglandins and histamines have been released into the eye, leading to further protein that's going to clog up the drainage angle. We talked about the different types of uveitic conditions. Don't forget, for pediatric scenarios, juvenile idiopathic arthritis. For adults, we think about infective and non-infective causes, granulomatous and non-granulomatous causes. But there's quite a few that might lead to uveitic glaucoma. Anything that causes uveitis might lead to glaucoma as a complication. The classic signs is, once again, we might get sneaky eye that are peripheral in nature. So you might get peripheral sneaky eye, that peripheral anterior sneaky eye, PASS, that effectively are a bit like our iris Bombay sign. The iris Bombay is the iris protruding forward and clogging up the angle. Well, the same happens with sneaky eye. There are sticky iris particles that essentially, from the periphery, clog up towards the corneal endothelium and clog the angle altogether, okay? So sneaky eye and iris Bombay cause blockage of the angle. You might get bulky ciliary bodies. So bulky ciliary bodies that are inflamed also cause the iris to kind of prolapse forward, if that makes sense, causing an iris Bombay sign, okay? And then you have other forms of signs that might be in keeping with acute or chronic uveitis, including nodules in the iris, perilimbal injections, pupil block, or oddly shaped irises, as well as systemic signs in keeping with the type of uveitic condition we're treating. Typically, no brainer, you have to treat the uveitic condition or the systemic condition to prevent glaucoma. So get that under control and you're golden, okay? Glaucoma should keep at bay. But in the meantime, you're trying to control with immunosuppressants and steroids, you might provide some ocular hypertensives, okay? So control the glaucoma whilst you get the condition under bay. But equally, if the condition's localized, quite a lot of interesting developments are happening with implantable steroids. So you have these things called, I think it's Ozurdex, as well as Elavian is one of the other pharmaceutical companies that basically place implantable steroids into the anterior chamber of the eye. And it's like a slow gradual release of steroid into the eye to keep the uveitic focal infection or uveitic inflammatory condition at bay. So steroids get the condition under control, and in the meantime, provide ocular hypertensives to prevent any further sight loss. Rubiotic glaucoma. I'm going to try and speed up, guys. I'm sorry. This is, as always, my timing's poor. Rubiotic glaucoma is primarily due to neovascularization. So we think about the conditions that cause ischemic insult to the eye. So this is diabetes, especially proliferative diabetes, as well as your vein occlusions and artery occlusions. Anything else that might be being occluded, for example, like a stroke, sickle cell crisis also. In proliferative diabetic retinopathy, we usually have proliferation, not because of the fact that it's an end stage form of diabetes, it's because there's been an ischemic attack and the eye is reacting by releasing vascular endothelial growth factor by saying, hey, there's been an ischemic attack because we're diabetic and unfortunately our arteries are clogged up. So please produce more kind of sufficient vessels. But in the process, the eye produces dysfunctional and weedy vessels in proliferative diabetic retinopathy. And these weedy vessels, amongst kind of forming around the iris, they might even form around the angle, causing a blockage there, okay? And this is known as Rubiotic Glaucoma. So we talked about neovascularization. The classic signs, once again, you get rubiosis iridis is one of the new ones where basically vessels form around the iris and you get this characteristic picture like this. You might have evidence of diabetic retinopathy on the retina, and you might have neovascularization of the actual trabecular meshwork, which is at the angle. Okay, so new vessels clog the area. It's known as the 100-day glaucoma. I think this is kind of an old term for it, but essentially it's because if you were to ever suffer an insult silently, such as a CRVO, a vein occlusion, and you weren't to notice it, within 100 days, 90 to 100 days, I think, you would develop glaucoma as a result of it because you'd have neovascularization, okay, in the angle. Management, once again, treat the underlying cause, which is the ischemic insult. So get the diabetes under control, do some photocoagulation therapy for the diabetes to prevent new vessel growth. If it's a CRAO, for example, you need to work the person up for a stroke, which is echocardiogram and carotid Dopplers, okay? And treat the elevated pressure whilst you're treating them for their systemic condition, okay? Traumatic glaucoma. This is, once again, a slightly no-brainer, but essentially blunt trauma leads to trabecular meshwork obstruction. So it's usually a closed angle glaucoma, unfortunately. So blunt trauma leads to what I like to describe as a coupe contra croup injury in the eye. And what I mean by coupe contra croup is there's kind of a site of insult, and then there's a subsequent effect on the opposite side. And because the eye is a fluid structure encased in connective tissue, when you do blunt trauma to one side of the eye, okay, the actual damage will be on the opposite side, unfortunately. There'll be damage, if severe enough, from this side as well as this side, essentially. So you have to think about the focal site as well as the contra croup site, or the opposite side. And that's just because of fluid dynamics, because the aqueous humor will transmit all that force very happily to the vitreous, through the lens, to the vitreous, to the other side, okay? So blunt trauma leads to this contra croup injury, okay? And this contra croup injury will affect very small, delicate structures. So typically the trabecular meshwork gets shafted whenever there's a traumatic injury, okay? So in early traumatic injury, you have obstruction to the actual trabecular meshwork through either blood collecting there or a pupil block, but eventually you have actual damage such as tears through this contra croup injury, or synechii start to form around that area, blocking the drainage angle. Ectopia lentis is just a fancy sign for essentially the lens is displaced, and here you can see the actual zonules being stretched to their upper limit. Iridiolysis, so sometimes the iris might clog up the drainage angle because of the fact that you've had essentially the iris ripped apart from its kind of connective tissues. And you will have, I was trying to remember what this meant, but you might sometimes get cleft formation in the actual drainage angle. So essentially the connective tissue that surrounds the drainage angle gets ripped apart. And this is quite a late sign of blunt injury. So once again, stabilize the patient if they've had an injury, okay? Obviously the eye probably wouldn't be the priority if they've had a significant injury, A, B, C, D, E. But otherwise, once you do get an ophthalmologist seen, you would put a protective eye shield, elevate the head to reduce pressure, as well as get blood pressure under control. You'd stop the people from spasming if you can with cycloplegics. You'd pop steroids in, you'd pop anti-ocular hypertensives, and eventually you need actual surgical correction of the underlying problem. So fix the iris, fix the cleft, or get the lens back in place so it's not protruding through the iris and putting pressure on the trabecular meshwork, okay? These two conditions are awesome. They've got very cool signs and everything like that. So I'm just gonna pop them all on here, but they're slightly rarer causes of glaucoma. I've popped them out there just so you're aware of them because they're quite popular Duke Elder questions, because Duke Elder loves the arbitrary and the mundane, the arbitrary and the wonderful. You have pseudo exfoliation syndrome. This is a systemic condition compared to pigment dispersion syndrome, which is more of a focal condition. Pseudo-exfoliation syndrome is protein that essentially leaks from basement membranes. So it sometimes can be found in the heart, lungs, and liver, and the kidneys for that matter. Filaments of protein leak from the basement membrane and they clog up the angle. Classically, in pseudo-exfoliation, you get this kind of moth-eaten appearance because there's no structural integrity to any of the endothelial or epithelial cells. Okay, so moth-eaten appearance. You can sometimes see exfoliation flakes, which is basically debris of protein floating around. Sometimes there might be irregular pigmentation in the trabecular meshwork, and it's classically called a Sampoliosi sign. Or you might get trans-illumination defects, a bit like pigment dispersion syndrome. And trans-illumination defects are essentially when an ophthalmologist shines a light into the eye and it manages to reach the retina, and then the retina reflects a bit of it back. And in a dark room with the retina reflecting it back, you essentially get defects that are seen, okay, in the iris because there's been pigment or protein that's left the iris as a result of it. So you get trans-illumination defects in both kind of syndromes, if that makes sense. Okay, I can talk you through that a bit more afterwards if anyone's still confused about that. But pigment dispersion syndrome is a bit similar like pseudo-exfoliation syndrome, but it's more local to the eye. It's usually when there's essentially pigment that rubs off the pigmented cells that form the iris as well as the ciliary bodies, and this pigment gets trapped in the trabecular meshwork. And typically you have a few classical signs that you might see on examination, okay? Pigment storm meaning there's just loads of protein around the area. Iris bowing is because there's sometimes inflammation that causes the iris to protrude forward, okay? TM, so the trabecular meshwork might be pigmented a bit more, once again, Sampoliosi sign. And you might get deposition, okay, of various things known as Krukenberg spindles, okay? And that's just deposition of protein. Once again, this is the weird and wonderful, but it's sometimes testable in the Duke Elder. And it's not a common cause of glaucoma, but it's something that makes glaucoma patients difficult to manage, as well as to do cataract surgery in these two conditions. I think this is the final one, malignant glaucoma. This one is a very difficult form of glaucoma, as the name suggests. And once again, we don't know much about it, but usually, I think the main important thing to realize is it's a type of glaucoma that follows usually penetrative surgery, okay, or any surgery that kind of attacks the vitreous, touches the lens, or enters the AC. And I believe when you enter or do this surgery, the reason we get malignant glaucoma is basically of a process known as aqueous misdirection. So how this happens, I'm not too certain. I don't think there's much literature out there, but through intraoperative surgery, there is the aqueous, or our kind of articulation within the eye, displaces a few anatomical structures, and so the aqueous flows in a different direction rather than flowing the usual kind of from posterior chamber forward into the trabecular meshwork. It flows instead into the vitreous, and by flowing into the vitreous, it then pushes the lens forward, which pushes forward into the AC, leading to closure of the trabecular meshwork or the angle. Okay. So here we typically see, once again, shallow AC, the classic signs of glaucoma, but no iris Bombay sign, which means there's no protrusion of the iris. It's kind of globally moved forward by the lens, okay? Iris Bombay is when the iris touches the cornea and gets stuck to it, okay? So in summary, glaucoma sadly is not boring. There's multiple causes for glaucoma, even including some exotic causes, okay? But the primary way to differentiate between everything is ensuring whether the angle is open or closed. The biggies are primary open angle glaucoma, as well as acute angle closure glaucoma. And then you just need to be aware of the other types, such as rubiotic, uveitic, pseudo-exfoliative pigment dispersion syndrome, okay, and normal tension glaucoma, which are slightly more exotic, okay? So investigations for glaucoma, we're almost there, guys. A couple more slides. The optic nerve is difficult to assess, okay? There's loads of features that you look for in an optic nerve, okay? So once again, let's just repeat this. We've got the optic cup, okay, which is the inner circle, the optic disc, which is the outer circle. Anything in between is known as the neuroretinal rim, okay? That's very rich in axons, okay? And then the optic cup is sorry, pardon me, the optic cup is not rich in axons, okay? It's actually quite deficient. So deficient, rich in axons, and then everything else travels in either a linear fashion or arcuate fashion to form the optic nerve, which is basically at the optic cup region, okay? When people refer to patients as having cupped optic discs, what they tend to mean is there's an asymmetry in one of their eyes, okay, compared to the other eye, where the optic disc, sorry, the optic cup looks bigger or slightly encroaching on the optic disc. So the optic cup is swollen almost. So this is cupping, for example, and this is a normal optic disc up here. This is a cupped optic disc and this is a normal. Now, the main thing to be aware of is sometimes people have larger optic cups and that's a normal process. The thing that distinguishes a glaucomatous eye or glaucoma suspect is when the optic cup is present in one eye, but not the other. In fact, if there isn't any difference in the cup to disc ratio, which you'd usually kind of measure, okay, vertically, all right, vertically. So you'd use the vertical distance of the optic cup and the vertical distance of the optic disc to create a ratio, which usually lies between 0.018, okay? If there's a difference between the two eyes, then that's a glaucoma suspect immediately. However, if there is symmetry between the eyes and they just have slightly larger cups, or sometimes the optic nerve travels in obliquely, so they might have oblique optic cups that look bigger but are actually physiological, this is reassuring. As long as there's symmetry, it's reassuring. So once you've accepted cup to disc ratio, which is not a very good sign, tend to these days, instead of relying on clinical diagnosis, we tend to put people through a scan anyway, called an OCT, to assess the optic cup. Okay, so I'll talk you through that. Color. So you look at the color of the optic cup, okay? If it's slightly more pale than normal, then they could be a glaucoma suspect. If the optic cup is shining bright like the sun, but the area around it is unfortunately looking slightly pale, i.e. the neuroretinal rim, so this area kind of around the optic cup, then there you must look for other causes of the optic neuropathy. Remember, glaucoma is an optic neuropathy plus visual field defects, but there are other causes for optic neuropathy, such as MS, okay? So look for another cause for the optic neuropathy. Then look at the contour of the cup and disc, okay? Sometimes focal notching, okay, means that there might be atrophy elsewhere. So for example, let's look at this cup here. Focal notching is kind of towards the, shall we say, 3 to 5 o'clock position here, okay? There's a bit more notching, it's asymmetric. There might be atrophy in this area, if that's what that means. And if the cup itself is symmetrical, but the surrounding area looks like it's atrophic, then there's global loss of retinal fibers. The ISNT rule, once again, so if some aspect of the cup looks more pale or bigger or notched than the other, then you go back to this rule essentially, the ISNT rule. The inferior tends to be larger than the superior aspect, that's larger than the nasal aspect, that's larger than the temporal aspect. And essentially what that means is it establishes certain diameters for how big the cup is, and it allows you to identify whether a cup is notched or not, okay? So you might, for example, construe this as a notched cup in the temporal region, but in fact, if you use the ISNT rule, you will realize that the temporal region tends to be smaller anyway between the cup and the disc. So this is actually not a notched optic cup, okay? Not a glaucoma suspect. But if this was beyond a certain measurement, for example, if it was out here, then you might suspect it to be notching and a potential glaucoma suspect. So I don't think you should know this in detail, how to assess an optic nerve, okay? It gets very, very detailed, but appreciate the kind of global aspects. There's a lot of stuff that you can talk about with an optic disc. Thankfully for our generation, scans are becoming a lot more common and are much more helpful than someone looking into the eye, the back of the eye, and trying to assess all this. Okay, scans are very helpful these days, and we'll talk them through. Other signs that you might see is saucerization, which is once again just enlargement of the cup. Bayoneting, this is when the kind of arteries do Z angles, various Z angle stuff. So they look a bit more kind of 90-degree turns, more 90-degree turns, etc. Might be indicating of some form of pathology. and peripapillary atrophy. And you'll see that usually around the optic disc. So you'll have like just basically really ganky looking like retina, okay? And that's peripapillary atrophy. It'll look just bad. Measuring IOP is one investigation that you'd like to do for patients with glaucoma, okay? So you use tonometry, for example. Tonometry, you have different types, but the main one we use in clinic is a Goldmann applanation tonometer. It basically uses this pressure over force over area, okay? And you see these two little things, these two little signs or squiggles, and you want basically the inner side of the squiggle to touch the other inner side of the squiggle. And then this thing gives you a measurement on a big kind of apparatus, okay, that's stuck onto your slit lamp. So when the squiggles touch, you get a value that's read off the machine, and that's Goldmann applanation tonometry. And you pop it onto the person's eye. It looks a bit weird and everything, and you pop some fluorescein on, but maybe a bit of topical anesthetic if they're a bit upset by the process. But you essentially get the squiggles to touch and you read off the value. Other types are Perkins Sonometry, which is a bit more portable, and you get non-contact tonometry, where basically a puff of air is wafted in the eye and a little thing jabs the eye repeatedly, okay, to measure a pressure. These are sadly less accurate, and this is the gold standard, a Goldmann applanation tonometer. Pachymetry is a measure of the corneal thickness. This is important because corneal thickness dictates whether we overestimate or underestimate the intraocular pressure. Thicker corneas give a higher reading of IOP. You might have someone, for example, with a thin cornea or thinning of the cornea in keratoconus, for example, and they will have a low IOP, but they might be actually a glaucoma suspect. So you need to do an equation eventually. When you've done someone's pachymetry and tonometry, you have a very smart equation that adds the two together and says whether their IOP is adjusted for corneal thickness or not. And then you can make a decision as to whether this person is a glaucoma suspect or not. So this is your assessment, corneal thickness and IOP. Then you look at the visual field. Remember, glaucoma is an optic neuropathy, okay? So there's death of axons on the back of the retina, but equally you need to have clinical signs, okay? And remember, glaucoma is an insidious, chronic, and devil's disease because of the fact that peripheral vision's lost first, so your eye doesn't notice it until there's significant visual field loss, okay? And we don't want people losing their central vision, so it's too late if you detect them at the central vision loss stage. Perimetry, okay, as the name suggests, you're looking at basically the visual fields, okay? There's two types, Goldmann, which is these two measurements. Patient sits down, has a look at this huge globe, and essentially various different stimuli appear in the same intensity and stuff like that. And the patient looks into those different things, and it basically attests vision that can be seen and vision that can't be seen. And you basically get a diagram like this. And you can see certain visual field defects. For example, here there's a superior defect. For example, you'll have certain baseline measurements to show what the normal distribution is of a visual field, okay? Then you have the Humphreys, which is essentially patient sticks head into a smaller globe, okay, and sees more dots and images, which are generated by a technician. And essentially the patient reports yes and no, whether they see those dots, and you kind of collate a visual field defect as a result of that. So both are similar, they both have different mechanisms, both have pros and cons. I think this one's a bit more expensive, so you're less likely to see it in the NHS. This one's a bit cheaper, so more likely to see it in the NHS essentially, but both are useful in assessing visual fields, okay? Also operator dependent and everything like that, so pros and cons to each. Other investigations, we talked about gonioscopes, okay, these prisms that look at the angle from a distance, look at the angle from your slit lamp, okay, just an extra lens that allows you to visualize the angle. So you might see these clefts, for example, in traumatic glaucoma, or you might see extra pigment if they, for example, have rubiotic glaucoma, or vessels even growing if they've got rubiotic glaucoma, or you might see iris nodules if they've got uveitic glaucoma. So loads of useful signs. And this is where the bad boys help us out. Scans of the back of the retina. Optical computed tomography, I think, ocular computed tomography, OCT for short, okay, measures the back of the retina and its thickness. And OCT has got so good these days that it's actually able to differentiate between the 10 plus layers of the retina. Heidelberg have produced the latest OCT scanner in about 2017, which has just got HD sexy images of the retina, okay? And it allows us to analyze the optic disc in a fantastic manner. And it's so good these days that you don't even need to do or bother with all these optic disc cup ratio stuff, okay, that exams tell us to learn, unfortunately. But when it comes to clinical practice, every ophthalmologist will send their patient for an OCT scan, and then computer says to them green or red, okay? Is there optic atrophy that's consistent with a normal distribution of the population? If it's the red, oh shit, this could be a glaucoma suspect patient. If it's in the green, fantastic, let's send them back for monitoring, okay? And you basically get these awesome scans that tell you whether the patient's decaying or not decaying in terms of their optic kind of thickness. This scan basically uses light waves to determine thickness of the retina. If there's axonal damage, then the retina starts to thin, including the optic cup. If there's optic atrophy or optic neuropathy, then you'll get a thinner optic nerve or an optic cup. And so this scan picks it up and it gives you nice green and red images to tell you whether you should be doing something about it. This is the future. Management of glaucoma, super quick, super quick. I'm so sorry for keeping you guys. You have two types of ocular hypertensives. One that increase the outflow, so they act on the trabecular meshwork essentially, or they act on the uveoscleral mechanism, which is 10% of the outflow, okay? These are your adrenergic agonists, such as adrenaline, topical adrenaline, your parasympathetics, ones that mimic the parasympathetic system, like pilocarpine, and your prostaglandins, okay, which basically act to increase trabecular outflow. I don't know why I've missed that here. And each carries its own side effects and profiles, and patients sometimes like them, don't like them, they agree with them. So you might trial a few before you try and get someone on optimum treatment. Then you have your other ocular hypertensives, which reduce aqueous production. So they primarily act on the ciliary body to tell the ciliary body, calm down, let's not produce as much aqueous, okay? The eye has enough. So these include your beta blockers, timolol, quite commonly used, your alpha-2 agonists, okay, for example, aproclonidine or brimonidine, okay, and your carbonic anhydrase inhibitors. Remember, we saw these with acute angle closure glaucoma. You'll pop IV carbonic anhydrase inhibitor, 500 milligrams, to reduce someone who's got acute angle closure. This includes acetazolamide. Each has its own side effects that sometimes are tolerated by patients or not, okay? When it comes to NICE guidelines, the primary first line is usually a prostaglandin analog or a beta blocker if it's not contraindicated in an asthmatic or odd heart rate or bradycardic patient, okay? So you give them a topical timolol or topical latanoprost. Some patients like latanoprost because it causes their eye to look funky. It causes discoloration of the iris / eyelash growth. So, if you're looking particularly sweet that day, it might be because of your topical latanoprost drops. Timolol is not tolerated well because of the systemic side effects sometimes. So it causes some people to have sudden heart problems or, heart palpitations or to go bratty. Brimonidine, dorzolamide, which are alpha-2 receptor agonists and carbonic anhydrase inhibitors, are your second lines. And then you might go for something like pilocarpine as last resort because of the fact that it's got quite a lot of systemic side effects, unfortunately, as well as making your vision very blurred because it acts on your accommodative reflex. If medical therapy fails, then we go to the cool stuff, the laser and the surgery, which I'll talk about rapidly. Once again, ophthalmologists are experts at combining medication and changing drops. So if there's, usually if people don't do well with first or second line medication, they'll do combinations of drugs. And sometimes you can get even 3 drugs in one. But this is an example of a few common ones. For example, Ganforth, Cosopt, Simbrinza. These are quite common commercial names for some of the drugs that are combo therapy. Okay, some cool videos. Hopefully they work, okay? So laser iridotomy is usually an acute procedure. I just forewarn you, okay? Laser iridotomy is usually for angle closure if you want to create a quick channel for patients to have new flow mechanism, okay? Once iridotomy is done, you sometimes go for surgical management. And the bad boy of surgical management is unfortunately a good old-fashioned trabeculectomy. And what a trabeculectomy does is it creates a reservoir. You basically create a pocket of scleral tissue, okay, outside the eye, and then you pierce it into the chamber, okay? You pierce it into the chamber, and it creates anterior chamber flow into the trabeculectomy. They're pretty good. they're very user dependent. So if you've got a very good ophthalmologist, then they'll create a fantastic trabeculectomy that can last you ages. If they're not, but they can get clogged up. So you need to give them sometimes some anticellular medications, such as like mitomycin, to help prevent the trabeculectomy from getting clogged up. So I'll just speed through this video. This is probably the fascinating stuff. So I don't know if you guys can hear it, but let's just talk it through. So she's creating an incision in the conjunctiva, okay? So she's forming the kind of first basis for a trabeculectomy. She's gonna start dissecting the sclera here, okay, the connective tissue, and she's gonna start forming basically her trapdoor, essentially, for her trabeculectomy, okay? So she's tamponading the blood vessels and she's gradually dissecting, creating a trapdoor / entry point into the anterior chamber that's coming from the sclera. Gradually, she's doing it, you know, very, very good. This is her trapdoor, okay? She's probably got entry into, as you can see, there's a bit of blood already in the aqueous chamber. So there's probably, sorry, in the anterior chamber, meaning she's probably already gained entry. And it's essentially creating a trapdoor. So what they'll do is they'll create this trapdoor, and eventually the patient gets a bleb. It's called a bleb, okay? And the trapdoor essentially allows drainage. So once this chamber starts draining, you'll create a bleb. And as a result, the patient will have a nice functioning bleb or reservoir for where aqueous can flow out. And sometimes patients get complications, as I mentioned. Sometimes there might be an obstruction. So you need to give them mitomycin injections, which is an anticellular medication to prevent proliferation of cells or kind of scar tissue forming, as well as they can get inflammation of the bleb, known as blebitis. The final procedure, oh, never mind. The final procedure is what is making glaucoma surgery really hot and sexy these days, and it's called minimally invasive glaucoma stents or glaucoma surgery. These are essentially stents that are placed in the trabecular meshwork or the angle, and they help drain the angle, okay? So I'm gonna show you a couple. This is him preparing the surgery. So this is it. He's got a kind of a gonioscope, okay? He's got a gonioscope here that's looking into the angle, and he's gonna place a stent in there. So he's aiming right for the angle, okay? And look at that. He's got a stent, boom, look at that. This is the Cypass Stent. A very big stent that's been placed into the angle, and that's going to help, like a pipe work, a new piece of pipe work that's going to let aqueous flow out of the eye. He's also popping another stent next to it, okay? Because usually on their own, they're pretty good, but usually you have one or two, or you do them in combination with another procedure. I think what he's popped there is probably a Zen stent or an eye stent, for example. So there are different types of stents that you can pop into these trabecular meshworks. Some are better than others, and they also carry their complications, but this is where the field's heading, popping stents into the trabecular meshwork. One example of a side effect is the fact that these stents rub on the corneal endothelium, and you might lose the corneal endothelium, which is a terrible complication, but it depends on the surgeon, once again, how far out the stent goes. Brilliant.